All right, let's talk about one of the most frustrating and frankly one of the most fascinating bugs we see in the clinical lab, Nocardia nova. It is a true master of disguise and a serious threat to our vulnerable patients. So in this explainer, we're going to break down what makes this pathogen tick and why getting the ID right is, quite literally, a matter of life and death.
So why the dramatic nickname? Why do we call it the Great Mimicker? Well, because you look at a chest x-ray and what you see could be tuberculosis, it could be a fungal ball, it could even be lung cancer. So how are you supposed to treat a patient when your top 3 differentials require completely different, sometimes opposing, therapies? That's the challenge. This isn't just some academic curiosity, it's a dangerous roadblock that delays life-saving treatment.
Just so you know, all the information for this explainer was pulled together using Gemini Deep Search. For all of you who want to go deeper and dig into the primary literature yourselves, and I know you're out there, we've got all the sources linked for you in the notebook. I definitely recommend checking it out.
Okay, first up, identifying the organism. We're going to start at the very beginning, from its confusing family tree to the classic clues we hunt for on the lab bench.
You know, the history of Nocardia nova is a perfect example of how molecular tools completely changed the game for microbiology. For decades, this thing was just buried inside the huge, messy bucket we called the Nocardia asteroides complex. Then, in 1982, it finally gets its own name. But it was the molecular work later on that really sealed the deal, proving that its unique antibiotic resistance profile wasn't just a fluke. It was the signature of a totally distinct species. And that's the whole point, right? Accurate speciation isn't just academic. It's your very first clue in predicting resistance and picking the right drug.
Okay, so let's get our eyes on the scope. Our first big clue is the gram stain. You're going to see these delicate, branching, gram-positive filaments. But the real key, look closely there, is that classic beaded appearance. That irregular, spotty staining is a hallmark that should immediately make the Nocardia alarm bells start ringing in your head.
Next up is the modified acid-fast stain. This is absolutely key for telling Nocardia apart from other filamentous bacteria like actinomyces. It's all because of the mycolic acids in its cell wall. It's just acid-fast enough to hold on to the stain when you decolorize with a weak acid, but it can't stand up to the strong stuff we use for mycobacteria. That partial positivity is a huge piece of the puzzle.
And on the culture plate, the clues are just as strong. You see these dry, chalky, kind of wrinkly-looking colonies, but honestly, the real giveaway is the smell. For any microbiologist who smelled it, that pungent, earthy, potting soil odor is completely unforgettable. It's a really powerful presumptive ID all on its own. And, just a word to the wise, it's a slow grower, so you gotta be patient with those plates.
Okay, section 2. Let's move from the bench to the bedside. Now that we know how to spot it in the lab, who's actually getting sick from Nocardia nova? And what does the infection look like in a person?
Clinically, you're usually looking at one of 3 main presentations. The most common is pulmonary nocardiosis, which just starts from breathing it in. But the really scary part is its ability to disseminate. This bug has a terrifying affinity for the central nervous system, where it forms brain abscesses that have a very high mortality rate. And then the third form is cutaneous, which can come from something as simple as getting a thorn prick in the garden, which directly inoculates the skin.
This chart really tells the whole story of who's most vulnerable. At its core, Nocardia nova is a classic opportunist. It targets patients with weakened cell-mediated immunity. So we're talking about transplant recipients, patients on chronic steroids, or people with cancer. In fact, sometimes an unexpected Nocardia infection can be the very first clue that a patient has an underlying immunodeficiency they didn't even know about.
All right, on to section 3, modern laboratory diagnosis. So while the classic methods give us some great clues, getting a definitive ID today means relying on more advanced tools, and each of them comes with its own set of challenges. Let's break them down.
Let's walk through this. First up, 16S sequencing. It's our usual gold standard for a lot of bacteria, right? But for Nocardia nova, its multiple different gene copies can lead to really ambiguous, uninterpretable results. Then you've got MALDI-TOF. It's fast, it's cheap, but it's only as good as your extraction method and your database. If those aren't optimized, it can fail you. So for the most accurate answer, we have multi-locus sequence analysis, or MLSA. It gives fantastic discrimination, but it's complex and really just used in reference labs. So the key takeaway here is pretty clear. There is no single magic bullet. A polyphasic approach that combines multiple methods is often what you need to be confident.
Okay, section 4, navigating treatment and resistance. This is where getting that accurate identification becomes so critical. We're going to look at the differences in international treatment guidelines and explore the totally paradoxical resistance profile that makes Nocardia nova so unique.
So when a patient is really sick and you need to start treatment empirically, there's no single global consensus. Broader international guidelines, for instance, often build their combination therapy around trimethoprim sulfamethoxazole. But then you look over at the Dutch SWAG guidelines, and their first choice is a combination of impendium and amikacin. These differences can come down to local resistance patterns or just differing expert opinions, which really underscores how crucial it is to know and follow your own regional guidelines.
And what about our pediatric patients? Well, the principles are exactly the same. Treatment follows the adult regimens. You're using combination therapy for severe disease with agents like TMP-SMX, imipenem, and amikacin. But of course, every single dose has to be carefully adjusted for body weight.
Now this is one of my favorite things about this organism. The Nocardia nova complex has a predictable, intrinsic resistance pattern that is so unique it can almost act as a diagnostic test all by itself.
This chart tells such a fascinating story. On the one hand, you see almost universal susceptibility to key drugs like linezolid and TMP-SMX. But then look all the way over on the right. It is almost completely resistant to amoxicillin clavulanate. That stark contrast is the key to its phenotypic fingerprint.
And this is the paradox that should set off alarm bells in the lab and isolate the tests susceptible to plain ampicillin but resistant to amoxicillin with a beta-lactamase inhibitor. That counterintuitive profile is the classic hallmark. If you see this pattern on your AST, you should be thinking Nocardia nova complex right away.
Before we get to the final challenge in testing, let's just quickly define our terms. Clinical breakpoints. They're just the standardized MIC values we all rely on to interpret our susceptibility results. They're what let us classify a bug as susceptible, intermediate, or resistant and guide therapy.
And this brings us to a major global discrepancy. In the US, labs use CLSI breakpoints to interpret susceptibility for Nocardia. But the European authority, EUCAST, has not published any clinical breakpoints for Nocardia species. This puts European labs in a really tough spot. They can report an MIC value, but they can't provide that crucial S, I, or R interpretation, which leaves clinicians to make treatment decisions without a clear standardized guide. It's a huge challenge.
Okay, Section 5. Let's wrap this up with how we can protect our most vulnerable patients and finish by considering the big questions that still remain in the field.
Since Nocardia nova is an environmental organism that lives in the soil, prevention really is all about minimizing exposure for at-risk individuals. And this just comes down to common sense advice: wearing gloves while you're gardening, using a mask in really dusty areas like construction sites, and practicing good, prompt wound care for any cuts or scrapes.
And that brings us to our final thought. It's really a question for all of us in both the microbiology and infectious disease communities. Without a harmonized global standard for susceptibility testing and interpretation for Nocardia, how can we truly be sure that we're providing the most optimal, evidence-based treatment for every single patient with this challenging infection?
So that's our look at Nocardia nova. If you found this useful, please subscribe to our channel. And we would love to hear from you in the comments. Your expertise is valuable. Whether you're an expert who's been dealing with this organism for years, or you're just learning about it, share your thoughts and your questions below. Thanks for watching.